Hello and welcome to Inside Exercise. I'm Emeritus Professor Glenn McConnell from Victoria University in Australia, and I'm also currently a Danish Diabetes and Endocrine Academy visiting professor at the University of Copenhagen in Denmark. The idea behind Inside Exercise is to bring to you the absolute who's who of exercise research. So exercise physiology, exercise metabolism, and exercise and health. And what I'm really wanting is for you to get your exercise information from the research experts rather than from influencers. And indeed, today I bring to you Associate Professor Morten Hostrup from the University of Copenhagen in Denmark. He's an expert on beta-2 agonists and their effect on muscle and exercise performance. So you'd be aware of beta-2 agonists when you think of Ventolin, the blue puffer that people with asthma tend to use. This helps open the airways in people with asthma. But as we talk about, it can also have acute and chronic effects on muscle and exercise performance. So these beta-2 agonists like Ventolin can increase power during sort of sprint type exercise and also increase muscle mass, but may actually have negative effects on endurance exercise. It needs to be considered that like all drugs, they can tend to have side effects. So the beta-2 agonists can have side effects as well. I found it really interesting. I think you will too. So stick around. It is, of course, better if you watch the whole podcast to get the full context. But if you wanted to jump around a little bit, so for example, if you didn't want to hear about the mechanisms so much as the performance effects, for example, you can look down at the notes and you'll see, for example, on YouTube, there's timestamps. If you click on the time, it'll move to that section. And on the other podcast platforms, you'll see the time, but you just can't click on it. You just manually move to that section. Also, if you could do me a favor, if you like, comment, subscribe, etc., the algorithm will be more likely to suggest Inside Exercise when people do a search. So enjoy the chat. Hi, Morten. How are you? Welcome to Inside Exercise.
Thanks a lot. Thank you for having me.
Oh, it's good to have you on. Actually, we had a bit of I almost had you on a couple of months ago, and then something happened, which I think is a fair enough excuse for why we've delayed it. What was that?
Well, I was basically called by my wife because she was at a late stage in her pregnancy, and she was going into regular labor activity. So after I had giving a talk, I had to go back home. But then actually it turned out to go in itself again, and we went on a whole more week before we were like initiated into labor-inducing drugs. So she had to take prostaglandins, and she's tried that before with our first child. This was our second. And already on the second day on these prostaglandin inducers, then we were just laying on the couch, and then there was this poop sound. And then she had a massive discharge of water. And I had to call my mother because she had to take care of our first child, and we had to go to obviously the hospital. But we didn't even went this far because she actually went into to actual labor in our parking lot. So we winded up calling an ambulance, and luckily we live in central Copenhagen, so there was an ambulance after say 3 or 4 minutes. And when the ambulance arrived, then our daughter was basically on her way out with the head. And 1 minute later, inside the ambulance, on her way to the hospital, she had born our second daughter, which she's called Lærke, and she's doing great today.
That's amazing. Well, I remember thinking you were pretty laid back because you hadn't even mentioned it. So we'd organized for you to come on this a couple of months ago. And then we're away, as you said, at this conference, like, 2 hours drive from your home. And you said, oh, the only thing is my wife was due like a week ago. I'm like, really? But, anyway, so it ended up being like 2 weeks late, I think, Anyway, great. Well, thanks. It's good to have you on. Okay, so we're going to talk about beta agonists and how they might. So, people probably know, some may not, that, Ventolin, so the blue one that people take when they feel tired, etc., is a beta agonist. use for asthma, but we're going to talk about how it might have other effects, might even be performance enhancing. But how about we start off talking about, what is asthma even? And then, we talk about what that is, and then how do people treat it, and then how might the treatment actually have other effects, etc.
Oh, yeah, sure. Let's. But like asthma really is just like a chronic disease, inflammatory disease, where you have airway symptoms related to that, basically coughing, wheezing, tightness, chest tightness, dyspnea every now and then, and it can come in various forms and various severities. But the core thing is really that you have airway inflammation that drives bronchoconstriction, and when you have this bronchoconstriction, this is where you feel you have to cough, and you might feel that you have difficulties breathing. And they come in various forms. As I said, you can have allergic phenotypes of asthma where it's mainly driven by pollen allergies, for instance, and you can have other triggers as well. So usually what we do see in endurance athletes as such is like they're more prone to develop asthma, and they are very prone to have a form where exercise in itself triggers asthma-like symptoms. So you have the exercise in itself triggering bronchoconstriction. And it's been called, commonly it's called exercise-induced bronchoconstriction. Now, there are new classifications of it, so it's sort of like what we would say as a whole lower airway dysfunction, basically.
Yeah, so maybe just let me tease it apart a little bit. So I guess people always think, these endurance athletes, they must have big lungs and big hearts and big, everything's bigger and better. But is it correct that the actual lung volume of endurance athletes is pretty normal on average? Or before we even talk about, how much air they're getting in and out with each breath, etc.
Well, in general, if you compare like the lung volumes and the functional aspect of their lung volumes, they tend to be larger in endurance athletes, at such between like 10 to 20% larger than the general population. So they do have larger lungs, and most of them also have a larger vital capacity. That's the functional part of the lung volume. But a lot of them will have, if we take the ratio then between how much air they can expire in 1 second, that's what we call a FEV1. That's a marker of their lung function and how constricted basically their lungs are, and the airflow that go through the lung. It tends to be relatively smaller sometimes than the general population, and that's an indication that they do have some residual bronchoconstriction, and usually due to either untreated asthma or due to exercise-induced bronchoconstriction.
Yeah. All right. Well, that's interesting, because I remember when I did undergrad and even masters and stuff, they were sort of saying, and even in the general physiology textbooks, there was talk about how the lung volumes and things were not, before we get into asthma, the actual lung volume, so how much air you can keep in your lungs, etc., is quite similar. And the training doesn't affect that. Now, is that wrong, or do they self-select? It
depends on which cohorts you look into. I mean, if you look into marathon or like the Kenyan runners, for instance, yeah, that's true. It wouldn't be that much different from the general population as such. But if you do look at cross-country skiers or swimmers, definitely their cohorts would have like 10 or 20% larger vital capacities than the general population.
And is that just because they're 10 or 20% larger? Because I guess the Kenyan distance runners and things are quite small. And what I'm getting at is it just structurally, is it just based on your size? Or I'm just wanting people to understand, because my feeling was the actual endurance training itself doesn't affect, you don't like grow bigger lungs.
Definitely, it's true that you cannot really train your lung volumes. There's still some debate as to whether, like, if you're a swimmer from early childhood, whether that in itself may induce a bit larger lungs. There are some Chinese studies look into that. They're not that thoroughly conducted, but in general, like size matters definitely in terms of lung size.
Okay. So even, I know I'm drilling down on this, but so if you just had the same sized person, same population, because as you say, once you start talking about, I guess, Asian studies, people tend to be smaller and whatever. So if you have like a Danish chap, such as yourself, same height, same weight, who's been endurance trained versus untrained, you would generally have the same lung volume and how much they could move. Well, okay, let's not talk about how much they can move, because that's where we're getting to with asthma, but lung volume, yeah?
Yeah, in general, yeah, but we tend to see in swimmers and cross-country skiers, even when we adjust for the size of the individuals, that they tend to have bigger. And that just may be sort of like a natural selection towards these sports.
Exactly. Yeah. All right, that makes, okay. Now, all right. Now, so what we're talking about there is some terms you talk about, like the vital capacity, which is how much. So if you just breathe in as much as you can and you breathe out as much as you can and you measure that volume, that's the vital capacity, how much you can actually use. And then a lot of people don't realize you end up with some air still left in there, which is the residual volume, which which
Mm-hmm.
if you get dumped in a rugby tackle or something, which people aren't probably going to be doing much in Denmark, you might get that knocked out of you, and then that's like, oh, I'm winded. But anyway, how much air you can move is one thing, but then how much you can move in 1 second, which is you touched on, yeah? And that's what they're interested in. And you're saying that if you've got asthma, you can't remove as much in 1 second. So the pipes basically narrower, the bronchioles. And you're saying that that tends to be higher on average in athletes, endurance athletes. Oh, yeah.
Yeah, it tends to be high in endurance athletes that say the absolute values. So if you have a chap, as you said before, who can expire or breathe out 4 liters maximally in 1 second, then typically an endurance athlete would be 4.5, 4.4 or more.
Okay.
But relatively to their vital capacity, it tends to be smaller.
Smaller. Yes. So it used to be like a ballpark was like, if you want to be able to breathe out about 80% of your total within 1 second. And if if it takes longer to get it out, then you've got a problem. Is that still what they're talking about? That sort of cutoff is 80% is normal?
Yeah, exactly. That's the cutoff. And so
right.
So if you're an asthmatic or an asthmatic athlete, that you would typically be, if you have uncontrolled asthma or untreated asthma, you would tend to be at 70% or below that.
Okay. And you're saying then that athletes, even though they've got a larger volume on average, whether it's self-selected or because they were training when they were kids and whatever, they tend to have lower. So they actually have on average more constriction, less able to get the air out quickly.
Yeah.
Okay. And what percentage are we talking about compared to the population of people that have asthma, I guess?
Yeah, so in Western countries, that could be Australia, Denmark, or whatever, like that would be typically 7 to 10% of the general population would have asthma. In some elite athlete cohorts, especially within endurance-dominated sports, it can be upwards of 50%.
50?
Yeah, half.
Wow. Okay. And these are endurance athletes, so they're obviously managing okay. So how do these people manage okay despite this? And why do they? Why are they higher? So I guess it's 2 points.
Yeah. Okay. So let's start with the latter point then. We still do not know actually. There are some reasonable hypotheses as to why. Like one thing is when you have sports with very high training volumes, you have a lot of training hours at a relatively high intensity, so you have a quite huge weekly respiratory workload, and so you have huge exchange of air going through your lungs every minute during training. So they train with quite high, what we call ventilation, and their training may be several hours, sometimes 2-3 hours long. So that is a stress in itself on the airways. and that in itself may contribute to the pathogenesis of developing asthma, basically, and exercise-induced bronchoconstriction, because we do see in some cohorts that if they do train a lot, then the airway hyperresponsiveness is greater, and that's basically a measure of if you have asthma or exercise-induced bronchoconstriction. A hallmark of that is basically you have hyper-reactive or hyper-responsive lungs to triggers. And you basically see in these cohorts that they trigger quite much to various agents that we can normally use to test whether the airways are hyper-responsive. So that's the main hypothesis right now, but we haven't established a causation yet.
That's really interesting. So I know you said some cohorts it's up to 50%, but do you ever feel if you just grabbed a whole bunch of 1,000 athletes, endurance athletes, would it be like 20% or something? Or are you saying it's the cohorts that do? That's right. I'm remembering now. I had Jerry Dempsey on, and he was talking about as well that the high ventilation, especially with cold air, could maybe cause these problems. So I guess you're maybe thinking about these cross-country skiers or something, is that right?
And not only cold air, because you see it in swimmers as well. And even though then there was my hypothesis with regards to chlorine and chlorinated air close to the pool. But even if you have the like very modern pools where you have very much controlled air environment and etc., we still see it. So it's not really like it's not that clear it should be related to chlorine, but we do see, at least with cold air, that it can also be a stress in itself.
All right. Now, what about so I asked that sort of second question and within the one question, which made it complicated. So what effect does it have on these people? Because what I was getting at is if up to 50% of people have asthma, but they're obviously doing well as endurance athletes, does that asthma actually affect their performance? So, if they take a Ventolin or something, does that improve their performance? Without taking it chronically, we're not talking about the stuff we'll talk about later.
No.
Just, yeah.
Well, first things first, like if you're an asthmatic athlete, would that make you unable to compete at the highest level compared to not having asthma? And we do see that athletes with asthma have no problems in competing at the highest level, regardless of the sport. Actually, we do see, if we look at the data from the Olympic Games, that asthmatic athletes in some sports, and swimming and cycling, for instance, win relatively more medals in individual disciplines during the Olympics, both summer and winter Olympics, than their non-asthmatic peers. So based on that fact alone, it doesn't seem that they're unable to compete. In fact, they're able to compete and they're able to win. Then you can say, well, why is that? Because we do not know why that is the fact. And that's across multiple Olympic Games. Some say it relates to better screening programs in the countries that do win a lot of medals. So if you screen more with respiratory tests of asthma, you find more. Another aspect could be this selection bias, where you have the athletes with the greater lungs, bigger heart. They're also more prone to also develop asthma then again, and there's a more naturally selected
because they're moving more air and
yeah. And then you have obviously, is it the pharmacotherapy they're on? So this is where your bronchodilators come into play, and glucocorticoids, etc.
All right, perfect. So we're going to get to that. I guess the one question is then, if they're not chronically treated, because we're going to talk about whether chronic taking of these beta-2 agonists that like Ventolin can have ergogenic effects and improve your performance. But if you're not treated and you just take Ventolin, do you actually improve your VO2 max and your lactate threshold and your performance?
Not at all. Not if you look at those specific markers like VO2 max. It's well established that beta-agonists do not, if you take them acutely, enhance your VO2 max. Doesn't enhance your maximal ventilation. Doesn't increase your lactate threshold, etc. Not at all.
Okay. Mm-hmm. And that's even if you're asthmatic or non-asthmatic, I guess, because that's the thing. Mm-hmm.
Yeah. Okay. So normally in these athletes, even if you use other bronchodilators as well, even though you increase then their FEV1 and their lung function, and hypothetically you would have more airflow and higher ventilation and thus higher VO2 max, we do not see it even in the ones who do have lower than normal FEV1 relative to their vital capacity. So, and that's because like FEV1 is seldom limited for performance in itself.
Yes.
And there are also other factors at play anyway when we do exercise. You have normal hormones going on with adrenaline, for instance, and you have inhibition of parasympathetic impulses as well.
Okay. Well, I guess it's also suggesting, as you say, the lungs aren't generally considered to be limiting to VO2 max. It's more like your cardiac output, etc., as well, right? So, but as you also touched on, you didn't say it, but the people, you can do these flow volume loops and things. So you know, maximum inspiration, maximum expiration. You look at the loop, and even during at the end of a VO2 max test, you're still sort of within that envelope, aren't you? You're not sort of using your maximum stuff.
Yeah, and even if you were at the edge of you touch upon those airflow volumes, even if you were at the edge of it, the effect of beta-agonist or another bronchodilator wouldn't overcome that anyway. So you have to like, it's only when you do it the opposite way around. They've done some studies where they really try to compromise the airflow by reducing it, basically manipulating it either mechanically or giving something that bronchoconstricts. And there you can see that it does have a negative effect, but it's quite unphysiological.
That's interesting. So even though you were saying these people with how much they can breathe out in 1 second compared to their total, so the FEV1 of, we were saying earlier, you want to be at least 80%. You're saying even people with like 70%, 65 or whatever, they're still totally fine during a VO2 max test without taking any Ventolin or anything. That's interesting. Yeah. And is that, I heard you touch on adrenaline being elevated and things. So is that because you sort of have your normal sort of methods in the body of causing of opening your airways that are going on anyway? That's sort of
you do have some normal mechanisms that dilate anyway. Yeah.
Yep.
But whether that itself is that important for you to trigger your VO2 max, I still think you need quite significant constriction as you perform the exercise.
All right. And the endurance as well, because I remember, I think it was Jerome Dempsey had all these studies. Well, someone was, they're talking about diaphragm fatigue and, like when the work of breathing is harder, it can affect your endurance and things like that. So just the fact that the work of the breathing would be a little bit harder when you've got, reduced airways, it's not enough. It's not enough to make a difference.
If it were this important, I think we would have seen it in some of our studies, but like there are at least 20-25 studies with different bronchodilators that looked into this, and none of them have showed anything.
All right. Well, I'm going to stop taking my. I think, as you know, I've got kind of crappy asthma, and I go to see respiratory physicians all the time and whatever. And I take inhaled steroids morning and night, and Ventolin before exercise sometimes. So there's no real rationale to take Ventolin before exercise. Then.
But it depends on what you do and what your purpose is. Like we talked VO2 max before. If it's to trigger VO2 max, then it doesn't seem to have an effect on that. But in fact, we have done studies, and we've done actually a recent study that was published 2 months ago, where we do show if you train with inhaled salbutamol, that's Ventolin, and you do your endurance training with that 3 times a week, then you actually you blunt your effect, your training effect on VO2 max. And we've shown that this before also with another short-acting beta agonist called terbutaline. So actually we do see if you use your bronchodilator in too much and in too high doses when you train in endurance sports, it potentially have some negative effects on VO2 max.
It has a negative effect on VO2 max. Okay. All right. Now that's getting interesting. And what do you think the mechanisms is there?
That's a good question. We mainly believe it's muscular effects, because we tend to see it have some negative effects on the oxidative capacity in skeletal muscle. And and that's perfectly consistent with the basic physiology, if you will. If you look at rodent models or cell models, if you treat animals with beta agonists in quite high doses, you do induce a slow to fast phenotype transition in skeletal muscle, so they become less oxidative and more glycolytic.
Okay, so this is getting towards where we're heading, which is, the people that are using it more for strength and things like that. All right, so why don't we just, because we've talked about sympathetic and we've touched on beta agonists and all this sort of stuff, why don't you just tell us a little bit about, sympathetic, parasympathetic nervous system, what it actually is there for, what it does, and then how you're going to end up, targeting the sympathetic side of it.
Yeah. So what's interesting in this about talking about is like when Ventolin or salbutamol is a beta agonist, so it affects the beta-2 adrenoceptors, which is part of the sympathetic nervous system. So, but on top of that, we have the autonomous nervous system, which is basically can be divided into sympathetic and the parasympathetic. So the sympathetic is really just your fight or flight, freeze response. So when you're had to run away from a lion or fight a lion or whatever, or you come into a state of shock, then it's basically your sympathetic nervous system that's at play. Whereas the parasympathetic, that's really what you could say the rest and digest system. That's when we sleep or we just ate a big meal and have to relax. So they work differently, basically, to modulate the overall body response to accommodate that. So when we have the parasympathetic, that's basically releasing hormones that helps us digest food, for instance, or make us relax, reduce our blood pressure, and just stay relaxed. Whereas the sympathetic is really using hormones, and in this case, norepinephrine and epinephrine, to really get the body up to speed in the various tissues. So that's helps us increase our heart rate and our respiratory rate and actually force development in muscles, etc. So it helps us react and perform, basically.
Exactly. And in case you say norepinephrine and epinephrine, in case people are, thinking there's also called noradrenaline and adrenaline. So when you say, I had an adrenaline shot or whatever, so you get a shock, you get adrenaline release, and then, as you say, the sympathetic nervous system is helping you to get away, so fight or flight. So as you said, heart rate higher, but also dilation of your eyes so you can see better, and dilation of your bronchioles. Yeah. So as you were saying, to get more air into the lungs. All right. So that's great. So then what are these beta2 agonists? So as you said, Ventolin. Do you want to just explain a little bit about what they're doing in the bronchioles and things, just, basically, and then we'll start thinking about what happens when you take it acutely, chronically, etc.
Well, if you have so beta agonists, as salbutamol, Ventolin, as you say, they're basically synthetically derived drugs that looks kind of similar to adrenaline, but they're designed so that they're a bit more selective towards the beta-2 adrenoceptor, and they work for a much longer duration. So adrenaline would only work for a couple of minutes, whereas the duration of action of Ventolin, for instance, that's 4 to 6 hours. And specifically, they're designed to target what we call the beta2-agonists, which is a receptor that's part of the sympathetic nervous system. And specifically, that is highly expressed in muscle tissue, and both what we call smooth muscle, cardiac muscle, and skeletal muscle. And what they're designed for mainly in pulmonology and respiratory medicine is to bronchodilate. And they do that basically by inducing smooth muscle relaxation. So around in your lungs, you have your bronchioles, that's the pipes, as you call it before. And around those pipes, you basically have some muscle cells, some smooth muscle cells. And the more contracted those cells are, the more they shrink the diameter of these pipes. So if you give a drug that makes the smooth muscles relax around those bronchioles, then you increase the diameter of the pipes and you can have more airflow going through them, basically. So that's what they're designed for, basically. What's interesting in this regard is like even though you inhale Ventolin or inhale salbutamol, if you will, the drug doesn't stay there. And you would know that if you're a smoker, for instance, like if you smoke, you will get the nicotine into your bloodstream and throughout your body. And that's because the lungs are so fairly high capillarization around the lung. So they have a huge circulation around the lung, and the distance between the surface of the lung to the bloodstream is quite small. So when you have these small molecules such as salbutamol, it would go into the bloodstream quite rapidly when you inhale it. And when it goes into the bloodstream, obviously it goes to other tissues that have a beta2 receptor. And that could be skeletal muscle, for instance. It could also be the heart. So if you go high enough in your doses with Ventolin, you would feel heartbeat immediately and an increase in pulse, for instance.
Right. Okay. And there are other, because I know I think you've done quite a lot of research with different types of beta2 agonists. So I keep saying Ventolin because that's the thing that salbutamol, which is what people are probably more familiar with. But there are, for example, clenbuterol and things like that. Which are the ones that are mainly used for asthma? And is clenbuterol, which I know some athletes use, is that used? When is that used? Just for normal health.
So salbutamol is by far the most commonly used one among athletes. And it's also the one that's normally prescribed for immediate bronchodilation. So they would do it whenever they feel it's necessary during their training, if they feel bronchoconstriction or coughing or whatever. Clenbuterol is quite old. I mean, salbutamol is also old. It's been on the market for half a century, like 50 years or something. Clenbuterol is also old, but it's not really used in Western countries at least anymore. And then because the other beta agonists out there on the market, it is much better. Basically, they're way more selective and the fewer side effects. And but clenbuterol is commonly abused. There's a big illicit use of them, basically in gyms around the world. And commonly used by individuals who want to either build muscle or cut, basically.
Okay. And I think, were you saying it's not particularly specific, but it does it work better if you want to be increasing your muscle size or something than Ventolin? Is that how it works?
No, I actually only think it's purely from out of anecdotes that people are using clenbuterol more than the other ones. It's because there was way more work on it in animals back in the 80s, and a lot of studies use clenbuterol because people did that before. So it's sort of like compounding effect within research. And okay. I think it's the same within the bodybuilding community, like they use clenbuterol because they hear from other who used it. But if you really put up a comparative study, I could name a lot of other beta agonists that are actually marketed to human use that would be more anabolic and be better
really?
at building muscle. So it's purely out of, I would say, historical ignorance towards the more newer generation beta agonists.
Okay, so why don't we start talking about that? So who are the athletes that are taking this, and how so what percent of athletes are taking it in different cohorts and things, and why are they taking it? So you've touched on maybe building muscle, etc., and obviously we've talked about asthma, but I just maybe explain how some people are taking it for asthma, some people are taking it for asthma plus other things, like other potential benefits, and some people are just taking it for the muscle effects.
Like in general, I would hope that the ones who take it among athletes do it because they have a confirmed diagnosis of asthma or exercise-induced bronchoconstriction, and that's purely out of a therapeutic purpose to help.
Which would be
relieve,
nice, exactly.
Yeah, to help relieve bronchoconstriction. Then you ask what's the prevalence really? It's difficult to say, hard to say, but would presumably follow quite well the prevalence of asthma and exercise-induced bronchoconstriction. So, as I said before, if you had a cohort where you have 50% asthmatics, you would know that those 50% would use a beta agonist.
Yes.
Because it's first-line treatment, basically. Whereas in other sports, that could be football or soccer, if you will, that would be maybe between 10 to 20%. So it's different from sport to sport, and also different how high the use is. So for instance, like the severity of asthma is usually quite higher in cross-country skiers, for instance. So they would presumably use higher doses weekly than say other individuals.
Actually, the other thing is, how you said ideally and hopefully most people that are taking these beta agonists like Ventolin are taking it because of their asthma, but then some of them may be taking it because they want ergogenic effects, so improved performance. I guess one way of looking at that is, generally it's suggested that you shouldn't just take Ventolin. You should be actually taking some sort of treatment as well, right? Such as a inhaled steroid or something like that. Do we know if these athletes that are is that one way of working out if they're taking it for their asthma or not? You know what I mean? If they're just taking the Ventolin, but they're not taking the inhaled steroids, would that suggest maybe they're taking it for other reasons?
Yeah. So, or
maybe they just got bad advice. I don't know.
Yeah. So if you follow normal treatment, international treatment guidelines, we have something called GINA guidelines. That definitely when you have someone with asthma, you would normally prescribe them with what's called a long-acting beta agonist together in combination therapy with an inhaled glucocorticoid. And that's what's called the controller therapy. That's what you use to sort of treat the underlying asthma and prevent that you even get bronchoconstriction when you do exercise if you're an athlete. So basically, if you need your Ventolin more than twice a week, then it's a symptom of poorly controlled asthma, and then you need to increase your dosing of the long-acting beta agonist together with the inhaled glucocorticoid or another control. And there are multiple different controller therapies. There are leukotriene antagonists. There are anticholinergics you can also use for to prevent bronchoconstriction. So the key thing is to control your asthma, control your symptoms so that you wouldn't need your Ventolin, basically. But we do see that there is an over-reliance on Ventolin or Butylin among athletes. So usually they're not, either they're not good enough at controlling their asthma, or it's too challenging for them to control the asthma.
Or they're taking it because they don't actually have asthma. They found a dodgy doctor who, because obviously if you're a serious athlete and you've got asthma.
It's possible with the regulations we do have now.
Yeah, because if you're a serious athlete with asthma, you'd like to think they'd be getting good advice, which would be to take the inhaled bronchodilator, which is this Ventolin, and have the treatment, which is the long-acting beta-agonist, plus the corticosteroid, so which is we call just say inhaled steroid for short. So if you're skeptical, you could say, well, these people that are having an over-reliance on Ventolin, they either don't have well-controlled asthma, or some of them are taking it for the benefits on muscle or whatever, and not for their asthma. Not for asthma.
It's not impossible, no.
All right. Now, you actually said, I don't want to suggest anything like that in this regard, but you actually said, I saw you give a talk and you said something like 90% of Norwegian skiers and Danish swimmers or something actually take these beta-2 agonists, these Ventolin. Yeah. So is it really that high?
Well, if we do like use surveys and look at these cohorts, like it would be up to like 90% that would have given a diagnosis that would that would allow a prescription for a prescription to take salbutamol. We cannot tell for sure whether they then taking the drug or in how much how often or in which doses. But
yep.
The rules are as such right now that you do not have to document asthma or exercise-induced bronchoconstriction to use, for instance, salbutamol in elite sports.
Okay, that's interesting, because I don't know about in Denmark, but in Australia you can actually get Ventolin without a prescription.
Yeah, and so basically the anti-doping regulations now are basically based on dosage thresholds. So so you don't have to document that you have airway hyperresponsiveness or asthma or anything. There are some dosing threshold. There's a dosing threshold for salbutamol and a couple of other beta agonists as well.
Okay.
And they're basically on the list, on the WADA's prohibited list, with these dosing thresholds to sort of like make it difficult to bypass the rules and get too large systemic effects.
Okay. So what is the dose? So I don't myself, I'll just tend to take one maybe. Although, to be honest, I never feel like it makes any difference. Sometimes I feel tight and sometimes I don't feel tight. Usually I do feel tight, actually, even though I'm on the inhaled steroids and the long acting. And, you know, if I'm going to do a hard exercise bout, I think, oh, maybe I should take a Ventolin, but I just take like one. How many puffs are the thresholds that you're allowed to take? And how many do you know people take generally?
Yeah, so generally, like your salbutamol or Ventolin inhaler, that would either come in a device where one puff equals either 100 micrograms or 200 micrograms. And the dosing threshold right now is 600 micrograms in any in any 8-hour period, not to exceed 1,600 micrograms in 24 hours. So if you have, say, a Ventolin inhaler device where the dose is 200 micrograms per puff, then you can basically only take 3 puffs.
Okay. All right. Yeah. Now we've been sort of skirting around these potential beneficial effects on performance of these beta-2 agonists, but I guess we haven't really talked about it. So what are the effects of, so I know you've done a lot of research on this. What is the effect of taking these? And I guess also how much of a dose do you give when you do these studies as well?
Yeah, we've done along the entire spectrum. So first, to establish some proof of concept that they could enhance performance, then we went quite high. And more recently, we've went to the limits of the current anti-doping regulations to look more into under how and under which circumstances might it affect performance.
And what are you finding?
Yeah, so basically, there are no question that they have a performance enhancing potential when you go to a certain dose, and that performance enhancing potential is either on muscle strength or power-dominated exercise, such as a sprint, for instance, where you need power development. That could be a Wingate test, like 30-second all out, 10-second all out. They do enhance performance during such type of tests. And obviously, as it is with all other drugs, it's a dose response effect. And the higher you go, obviously, the higher the effect. So what's interesting here is really to know how low can you go, basically, and can you achieve an effect within the current regulations. These are the most important questions right now.
Okay, so the studies that you've done, and you and others, I guess, where you found increases in, I guess, power or force, or you can maybe clarify, were they at higher doses than you could ever give, to be within the drug testing limits?
Some of them were within the current regulations. I mean, we published a study only a few months ago where we used a long-acting beta agonist called formoterol. That's the second most common beta agonist among athletes. And we just gave the maximum dose by inhalation as water allows. And that had a performance-enhancing effect in elite cyclists.
Okay.
And this was on sprinting peak power and on a 4-minute time trial. So quite short but intense bout of cycling.
And you mentioned earlier that these beta-2 agonists can actually cause a fiber type transition from slow to fast. Did you actually see that? Have you looked at that in those studies, or?
The one I just referred to is where we only gave one dose, one-off high dose, and acutely measured performance. Yeah.
Okay.
Yeah. So if the one you're talking about when you want to see a transition in fiber type, that's what you have to take it for a longer duration. There, you have to induce some transcription and some proteome changes to induce.
Yeah, I didn't realize that. Acute.
Yeah.
Okay. I guess I'm getting confused because at the start we were saying how bronchoconstriction and things won't affect acute, VO2 max, lactate threshold, endurance, performance, whatever. But aren't you saying there that you found with just acute bronchodilators, you actually did find improvements?
No, not only us. I mean, it's been shown since like the late 90s.
Okay. Well, I guess because I was talking about VO2 max and endurance performance. You're talking about strength.
Yeah. So let's just say acute then first. Acute, most studies find absolutely no effects on endurance, VO2 max.
Yes. I'm very endurance centric. I think that's what we're finding here, this podcast. I always think about endurance.
On the contrary, if you look at more power dominated types of exercises where you have a large anaerobic component or power development, or a lot of studies have also shown since the 90s that they have a potential ergogenic effect on those types of tests. So that could be muscle strength, peak and mean power performance during 10 to 30 second all out sprinting, etc. So these are the acute effects if you only do once. And there's obviously a dose response effect.
My apologies. Yeah, I was thinking, I always think endurance. Yeah. So with endurance, no effect because you're talking about VO2 max, lactate threshold, economy, things like that. That doesn't affect that. But it has an acute effect on power, force, etc. Now, do we know what the mechanisms are for that?
Yeah, we have a pretty good understanding if we look across various sciences, and then you can sort of like connect the dots. So you get now it's more technical. So you have the beta-2 adrenoceptors in skeletal muscle, and then salbutamol comes past one of these receptors, binds to it, and activates what's called a signaling event inside this skeletal muscle fibers. And those events will eventually work so that the muscle cells are able to contract a bit faster and more, and to a great extent. So we know there are some vesicular structures, large vesicular structures called the sarcoplasmic reticulum. And on that sarcoplasmic reticulum, they store calcium. And that calcium is needed for the muscles to contract. The more calcium that are released from these vesicles, the more the muscles contract, the more strength they develop. Beta2 agonists by the beta2 adrenergic receptors act on some of the proteins of the sarcoplasmic reticulum and make them release more calcium per action potential that goes to that skeletal muscle.
I'll just interject quickly.
Yeah.
I've for people, I include timestamps in the notes. So I purposely will say mechanisms, and then people can go, oh, that's a bit too much for me or whatever. So we'll move back and forth. People can jump around a bit looking at the timestamps and pick the bits they want to listen to. But it's always better to listen to the whole thing. But yeah, keep going.
Yeah, so it's via some channels called the ryanodine receptors, and it increases the opening probability of those, so that more calcium is released, and more calcium will bind to something called troponin C, which then initiate the cross bridges, which help the muscle-induced force. Because we know this from animal models, if we knock out those sites, these specific signaling sites at the sarcoplasmic reticulums, the effect of beta agonists on muscle force doesn't work anymore then. That's one of a great researcher called Daniel Anderson and some of the works he's done specifically on that. And it also makes it makes sense, I guess, if you feel the adrenaline rush, when you get the adrenaline rush, you're able to react quicker. That's a skeletal muscle effect, or neuromuscular effect. And basically these drugs are like synthetic adrenaline that just work more selectively and work for a longer duration. I
guess also adrenaline's been shown to stimulate muscle glycogen breakdown as well.
Yeah, I mean, we see this as well in some of the studies. Some of the studies we've done ourselves, if we give it in high enough doses, make them perform intense exercise, they have a larger glycogen breakdown with beta agonists as well, and a larger production of lactate, etc.
Okay, what about reaction speed? That'll be a bit of a hard one. No difference in that, I guess.
There are some that's looked at rate of force development, see that's greater. I'm not sure in terms of reaction speed. On sprint, if you just have a like running sprint, someone go and then you run, then they're faster there as well, but that's not necessarily due to reaction as
Yeah, well, that's very interesting then. Okay, so we don't want to be condoning people taking these things, but that sounds pretty interesting for someone who's doing force and power type exercise. And just, sorry if you said, but just to clarify, was that within the legal limit as well, the dose that you gave, or?
Most of these studies that looked at muscle strength and sprintability, they go high. So that would be above the limits, but there are some studies within the current dosing limits that do see an enhanced effect. And as I alluded to before, we have a recent study where we tested formoterol to its limits acutely and saw a significant effect on sprint performance.
Okay.
In these elite cyclists.
So what do we do about this? I mean, I guess we don't want people taking drugs to improve performance. Do you think the limits should be lowered? Do you think there should be more proof that the person's really an asthmatic? I mean, what do you think? Or do you think we just let people go? I don't know. It's a tricky one.
Yeah, it's a tricky one because so many athletes do have asthma, do develop asthma and airway hyperresponsiveness. So obviously we want them to be able to compete and get treated with first-line treatment. And beta agonists are really like the first-line treatment, the first choice of drugs that any respiratory physician would choose. So it is difficult. But it's also important that that it doesn't like give them an unfair benefit against their non-asthmatic peers. So there's also sort of like a fair play aspect to it. So WADA have reacted over the years. So when I started doing research, like athletes were allowed to take 1,600 micrograms salbutamol at once as a single off dose. And they have lowered this now to 600 only, as I said before. 600.
A big drop, isn't it? Mm-hmm. Mm-hmm.
Yeah, due to some of these concerns. And it's a discussion right now with formoterol if there should be imposed more restrictions towards the doses that are allowed there. They allow quite high inhaled dose of formoterol relative to what's normally used clinically.
Oh, so you're saying that in theory that could be lowered because it's a higher dose than people would usually use?
Yeah, I mean it might even be half of what it is right now, the dosing limit.
Okay, so that's
there's a lot of
effects.
but there's a lot of stakeholders in this, and I mean this is just, I mean we have 2 studies now with formoterol showing this problem, and there's also a group in England who showed that formoterol may enhance sprint performance as well. So they're slowly becoming more aware of this, but you know it's a process that can take years before they enforce new changes.
Okay, so that's acute effects. Yes, is there any more you want to say about acute stuff, and then we talk about chronic, or?
No, we can proceed.
All right, thank you very much. All right, so what about chronic then? So then you're talking about things like, you know, maybe changes in fiber type and all sorts of things. So what happens with chronic beta-2 agonist inhalation?
Okay, so basically there's different mechanisms at play. So when again you have your drug and you have your beta agonist, it binds to the beta-2 adrenaline receptors, it affects some of the things I talked about before, but it's also a signaling molecule. The signaling also induces what's called transcription programs in the skeletal muscle fibers that makes the muscle fiber adapt to this stress. And the stress here is the beta agonist signaling. That's the stress on the muscle. And obviously, when you have this cumulative every day, say you treat with beta agonist every day, you have these gene programs that beta agonist affect that becomes more and more translated into proteins, and then you will see a phenotypic change over time. And what are those? Those are basically slow to fast phenotype transition of the fibers. They become less oxidative, say less endurant, but become more glycolytic and faster. So they go from what you would call type 1 fibers towards more like what we call type 2A and 2X fibers, basically. And this has been shown quite consistent, again, from various sciences, all the way from cell lines, cell model systems, to various animals, mice, rodents, even pigs. And we've shown it in humans as well. It's not as evident in humans than it is in mice, as it is with a lot of other things, but we do see a bit of a phenotypic shift in our studies as well.
That's interesting. So how much are we talking about? So in case people don't know, the average person's probably 50-50 slow twitch, fast twitch. And if you had the average person and you took these for, I don't know, weeks, months, what sort of change would you expect to see in the?
Yeah, it's difficult because like sometimes it's only a tendency we see due to these analyses are associated with a large variability. In some of our studies, we do see a significant change. But I would say if you used it chronically for, let's say, 1 or 2 months in quite high doses, that would be perhaps a 5% shift.
5% shift.
Yeah.
Okay.
And that's for the contractile elements of it, like the myosin heavy change, what we call it. We do see a shift in sort of like the oxidative to glycolytic part of it quicker. So we do see a decline in oxidative enzymes, but I see a rise in expression of glycolytic enzymes. That happens more quickly.
Yeah, just to make sure people are clear on that. So we talk about as a slow twitch muscle fiber is more aerobic, so it has lots of aerobic enzymes that can use oxygen and produce energy, but they also have a slower type contraction. So you're saying the actual change in the contraction speed from like slow to fast has a different time course to the change in the sort of aerobic enzymes and things, the ability to use oxygen. And which one did you say was faster? The aerobic enzymes going down is faster than the contractile.
Yeah, exactly. Or it's more evident, it's more clear, it's more apparent, at least when we look at human skeletal
it's more
muscle.
apparent as well. Okay, okay. So maybe 5%, 10%. Do you think that's enough to account for any? Well, I guess you're finding also then that you said acute can increase your force, your power. You said 30-second sprint, etc. Then I'm guessing you get like a bit of an additive, is it? So when you do the chronic, you'll get an improvement in that you can also top up with another acute.
Yeah, definitely. I mean, so that was some of the mechanistic part of it. Like, there's another aspect to it. Like, if you give beta-agonists chronically, you also induce muscle hypertrophy. So your muscles will grow, basically. So you have two sides of it. You have the muscle growth aspect, and then you have your fiber type transition aspect. And you would assume, in terms of basic physiology, that combining those two things together would then give rise to a greater muscle strength, for instance, or a greater power development. And that's also been the case for the past studies that have been done in this area within the past 30 years, going all the way back to Lucy Martineau from the early 90s, showing this with salbutamol. And back then they treated healthy individuals with the oral salbutamol tablets for 2 or 3 weeks, and saw quite massive increases in muscle force of around 20-25% increase.
And how many? Just a few weeks, did you say?
Yeah, 2 to 3 weeks.
That's massive.
It was 3 to 4 weeks. I can't remember. Around 3 weeks.
There's big changes. And this is, I guess they wouldn't have had massive hypertrophy in that time, would they?
Unfortunately, they only used skin fold thickness measurements and bioimpedance, so they couldn't see clearly. But back then, but we've shown since that there is significant hypertrophy as well.
And how quickly do you see that?
In some of our unpublished studies right now, we do with clenbuterol, we can see it after 2 weeks already.
2 weeks do you get hypertrophy? And these are just people taking it that aren't doing weight training or anything. They're just taking the beta2-agonist.
In that particular study, yes. But like, they're quite additive with resistance training, for instance. We also did a study, and that's published a few years ago, where we gave young men oral salbutamol for 10 weeks combined with resistance training. And when they did resistance training with placebo, they gained around 2.5 kilos or something lean mass. But if we added salbutamol on top of it, like, it gave around 1.5 kilograms more in lean mass.
Ooh. Okay, so that's a lot.
So it's not just clenbuterol; it's also salbutamol, and we also shown it with terbutaline, whereas there's dose dependency course as well. If you go quite high, you are able to gain around 1.5 to 2 kilograms of muscle mass. Some of our other research group. Nice study by Atkinson and co-workers back from, I think it's the late 80s. They treated young individuals, healthy individuals, for only 2 weeks with oral terbutaline. And terbutaline is almost identical to salbutamol. It's used in Northern Europe, short-acting beta-agonist. Treated those men for 2 weeks with terbutaline. They gained 1.4 kilograms of muscle mass with that. And that was with deuterium oxide measurements. So they were quite, it's a quite well-established method to assess muscle mass.
And that was without rate resistance training, or was that again on top?
Yeah, that was just habitual. They did go about whatever they did.
That's amazing, because usually my understanding was, people taking anabolic steroids, testosterone or growth hormone or something like that, if you're not actually doing resistance training, there wouldn't generally be much of a change in your muscle mass. Is that right? Have I got that right? But you're seeing with these beta-2 agonists, you're getting increases in muscle mass without doing any exercise training.
Yeah, it's been shown. We've shown it with, and not only we, as I alluded to before, other research groups have as well shown it in with different types of beta agonists under different circumstances, different doses.
Yeah, sorry. What I was clarifying is with testosterone and growth hormone, you don't see that. Is that right? You've got to actually do the training to see, I think.
Not necessarily. It depends on the study. I mean, with growth hormones, most of the studies, you do have to do the resistance training on top, and it's only, as I recall it, in elder individuals who have growth hormone deficiency. Really.
Deficient, exactly.
Yeah. With testosterone, you can achieve an increase in muscle mass without like changing training habits.
Without? Okay, yeah. That's interesting. All right. So these are, I guess, in my mind, because you've said, we've known for 20, 30 years or something. I guess I haven't been aware of that research. I haven't looked at it. We tend to think about bodybuilders and people that are trying to increase their strength. We tend to think if they're going to do something drug related, it would be anabolic steroids, growth hormone, or whatever. Have people been taking these things, across the years? Is that part of their sort of toolkit? These people that are taking drugs for increasing mass and size and strength and speed and.
Yeah. There are various surveys, particularly in the US. It's not like everyone does it, but maybe some surveys show around 1/3 of all bodybuilders in the US, or in California at least, some of the California gyms, they use clenbuterol or salbutamol. Yeah, so there is a high use, and there were some what's called pharmacovalence studies from the European Union not that long ago, where they could see there was a huge off-label use of Ventolin, and an off-label use of a drug indicates that there's something going on that shouldn't be going on.
Mm-hmm. Now, what about these? Are these things? I guess the mechanisms are different. So, are they the other sort of drugs that people are taking? So, whether it's steroids, it's the growth hormone. Do they act differently? Are they additive? Are they? Do you know? I'm not sure if you've looked into that or thought about that.
So the question is really if I take beta agonists together with testosterone, for instance.
Yeah, exactly. It sounds like we're actually giving people telling people what to do here. We're actually saying you should not be, ideally would not do that, but yeah.
Yeah, but we may come into side effects later, but I'm not aware of any studies that looked into that specifically, not even in animals.
Because knowing bodybuilders, at one stage when I was at the University of Melbourne, I was giving some lectures to medical students. They actually got me to give a talk on anabolic steroids and athletes. And there was actually a student that I saw in the audience. I thought, this guy's obviously a bodybuilder. He actually gave me his program of what he did. And it was just incredible. It was all periodized and, taking growth hormone here and anabolic steroids here, and then cortisol here, and then insulin, whatever. I don't think he had beta agonists in there, but I'm sure they're not just taking one thing. They're trying to optimize things, but who knows? Sometimes the science is behind the athletes in terms of what.
Sometimes it's salbutamol. They have there instead of clenbuterol. Sometimes they have ractopamine, which is a beta agonist combined with beta-1. But there are a lot of surveys and similar data on how they use beta agonists during their cycles. So usually bodybuilders would use, for instance, clenbuterol when they are reducing their use of anabolic steroids. So when they go off anabolic steroid, for instance, they increase the dose of clenbuterol to sort of like at least retain muscle mass during the period they are off testosterone derivatives.
Yeah, and as I said, let's make it clear, we're not suggesting people, because people could be listening to this and going, oh, okay, well, that's what I should do. We're not suggesting that in the least. And we will be talking about side effects. Now, one thing I know I spoke to you when you gave the talk a couple of months ago. I asked you a question and I said, these, you know how you said we're talking about the long-acting beta agonists for the bronchodilation, but also you tend to take an inhaled steroid, so a corticosteroid. And I asked you, because generally you think of corticosteroids as being kind of catabolic, so sort of breaking down tissue, while beta-2 agonists are anabolic, so, you know, building muscle. And I was assuming that sort of cancel out or something, but you gave an interesting response there in terms of effective corticosteroids on beta-2 agonists, so receptors. Why don't you tell us about that?
Yeah, so for sure, like if you give glucocorticoids or inhales or steroids like glucocorticoids, they're catabolic. You can see from various studies that you decrease your muscle mass if you take them for a longer duration. And the question is really here, asthmatics would normally take their beta agonist together with in a combined inhaler device together with an inhaled steroid. So what that didn't negate then the hypertrophic effect of the beta agonist. And the question is really there, we do not know in humans because it's not been done, but we do know some other things. We do know that actually glucocorticoid have a synergistic effect on your effective beta agonist. So if you use glucocorticoid, then you will have an increased density of beta-2 adrenoreceptors and therefore greater response when you use your beta agonist. And that's part of the reason why you give glucocorticoids to people using beta agonists. Like it's twofold, because the glucocorticoid is also given to reduce airway inflammation, but it's also given because it maintains the effect of beta agonist. Because if you just take beta agonist every day, you will slowly have a tolerance development, because you lose receptors, so to say. And that's the body's way to say, okay, we're overexposed to beta agonists right now. Okay, we lower our receptor content then. But that effect is reversed by glucocorticoid, that it increases the content of beta-2 adrenoreceptors and maintain the effect of the beta agonist. That's one aspect. Then actually, okay, what we do not know in humans, basically, because we've not looked into the effect of this combination therapy on muscle growth as such. But there are studies in animals that look into this, where they treated mice with clenbuterol, with dexamethasone, which is a glucocorticoid, and combined the two. And it's pretty clear. You do see if you give them clenbuterol, it induces massive growth. If you give them dexamethasone, it lowers the muscle mass a bit. But if you give it in combination, you actually still get a bit of muscle growth. Some of the effect of clenbuterol is negated, but not all of it. So that's what we really know right now about this.
That's interesting, but it's not
in terms of muscle mass, at least.
Muscle mass. Okay, I'll just make sure people are clear on all that. So that's really interesting, because you know, we all know that some people just take Ventolin. You know, they say, oh, I've got asthma, and they just take Ventolin, so salbutamol. And I often to say, well, don't you need to also take something, you know, a treatment? Because all you're doing is opening the airways. But if you've got that inflammation, you're not really dealing with the inflammation. So as you say, if you're properly controlled, or the idea is you take the Ventolin, but also you take the long-acting, and ideally you won't need much Ventolin because you're taking the long-acting beta agonist and the corticosteroid to work on the inflammation. Now, not only is it important that they do that, but if they're not doing that, if they're just taking the Ventolin, as you said, you actually get a sensitization. So the Ventolin actually stops working as well. So there's a very important reason. And you said that's actually one of the main reasons almost. Well, a important reason for taking the long-acting beta agonist and the corticosteroid is that the corticosteroid will actually increase your beta-2 receptors so that the Ventolin will keep working.
Any sane respiratory physician who would follow the normal guidelines would never prescribe a long-acting beta agonist without an inhaled glucocorticoid as well.
Mm-hmm.
There is even a black box label warning by the FDA on the long-acting beta agonist salmeterol, where it's clearly stated that you have to give it together with an inhaled glucocorticoid. Because
they usually come together anyway. Yeah, exactly.
Yeah,
but what about all the people though? We all know people that are just taking Ventolin.
Yeah.
So that's going to be a problem, right? They'll get the desensitization. Exactly. But it feels like that's most people. I often meet people, I've got asthma, and okay. So you're taking this one and this one? Oh, no, I just take the blue one. So.
Yeah, and that's inconsistent with the current guidelines.
Yeah, exactly. All right, but that's interesting. All right, but then you said in the animal studies, because you were saying taking the corticosteroid actually increases beta-2 receptors. So they didn't actually do better. Like the muscle mass wasn't actually even better than doing the beta-2 alone.
No,
okay,
but at least it didn't negate it as some. It was still evident, and particularly in oxidative dominated muscles, actually soleus, it had no attenuating effect on clenbuterol in that animal study, at least.
Okay, and now with the chronic, so we talked about acute, and then we talked about chronic. Two things. So with the chronic beta-2 agonists, you said that you get an increase in muscle mass and transition to more fast phenotype. That is within the normal, within the prescribed doses, not just the really high doses. Yeah.
Again, it's mostly in the high dose. We have shown it in some of our most recent studies that you are able within the current dosing limits to get a slight anabolic effect, but it's not large. It's only around 0.5 kilo muscle mass over a duration of approximately 4 weeks to 6 weeks.
Okay, great. All right. Now, what about health? Okay, so there's a couple of different things to health. Not sure what order we talk about it, but I know you've looked at sort of insulin sensitizing and glucose sort of metabolism and things like that, but also maybe side effects. Why don't we talk about side effects first? Because I don't want people racing off getting Ventolin off label and sort of going nuts and whatever. So why don't we think a little bit about, are there side effects to these things?
Yeah, as with any drug that works, there's also side effects. There are also a lot of side effects, basically. And it do happen that some individuals who have a illicit high use of beta agonists occasionally have a fatal outcome where they die. It's not common though, but it shows us that it is dangerous, and usually it's from cardiotoxic effects. So if you go quite high, and because you have beta-2 adrenoceptors in the heart as well, and heart muscle, that's the same process is going on. So if you use it in high dose for long duration, you will have cardiac hypertrophy and morphological changes in the heart. So that's the most concerning ones, basically. Also, then there's the disturbances in electrolyte balance. Why is that important? That's important because if you have too large disturbances in potassium, for instance, then it can induce arrhythmias and heart attack. So if you go too high doses, you will have a severe hypokalemic response. That's very low potassium in blood, and that's not good.
Okay.
So those are some of the effects, side effects.
And do we know that these side effects are sort of only in people that take like mega doses for a long time, or can it be something that's just sort of at the higher dose?
No, to be flat and fair, that's only in people that go very high. And to be fair towards Ventolin, salbutamol, etc., like these drugs, they've been on the market for 50 years. We know their safety profile quite well. There are side effects to them, but as long as you go normal therapeutic regimens, I mean, they're quite safe to use. So it's only when you like go high.
I guess it gets a little bit hard to tell if you've got. I think you said at one stage 20 to 30% of bodybuilders are taking beta-2 agonists, and that's probably above the percentage that has asthma. I guess it's hard to tell what would be causing the problems if they did have heart problems, for example, because some of them would be taking other drugs as well.
It would be very difficult to tell, but some of these cases, presumably they've used anabolic steroids, have a whole lot of different effect on their heart, which are negative. But in some of these cases, they came in with like arrhythmias, hypokalemia, found high traces of clenbuterol in the blood. So again, it's fair at least to say it's not a good combination to do anabolic steroids then and do beta agonist high dose on top of it at least.
That's true. Now, I just realized I forgot to ask you, we talked about mechanisms with the acute, you talked about calcium release and things like that. And then we talked about mechanisms with chronic. We talked about changes of slow to more fast phenotype, maybe not massive percentages. But do we know any other mechanisms there that are going on? So I'll do another warning, mechanisms for people if they wanted to skip forward here.
Other mechanisms in terms of the acute or chronic?
The chronic.
What could those be? In skeletal muscle, there's a whole lot of things going on. I mean, there's this oxidative to glycolytic, there are muscle growth, there are contractile shifts. There can be changes in the ion transport systems, the sodium potassium pumps. In terms of metabolism, they become way more dependent on glycolytic metabolism, obviously, and are able to produce more lactate as well.
With the hypertrophy, is it? With the hypertrophy, is it affecting things like? Again, people have a warning. mTOR, and do we know is there greater protein synthesis rates, or do we know that sort of?
Yeah, it increases protein balance. I mean, it induces a more positive protein balance, and both after resistance exercise, but also if you don't do anything. And that's in some studies, rodent studies, they've shown that it can be related to. Also, in one of the studies I did myself, it stimulates protein synthesis, but it also attenuates protein breakdown.
Oh, really?
And that's specifically in animal studies. And so an overall net positive protein balance when you give it. And some of it is mTOR dependent. But as you know, there are multiple signaling pathways that could be responsive for this. What you perhaps are alluding to with these insulin sensitizing effects or whatever, we do also see that the insulin sensitivity increases a bit when you treat chronically with beta agonists. And that's not only my research group, we've shown this with a drug called terbutaline, a beta agonist called terbutaline, but there are also other research groups that's shown it with clenbuterol in humans.
Okay, and that's chronic. Okay, so is that related to the greater muscle mass, or do you think it's having other effects?
Well, in our studies, we could see that was at least an association between the increase in muscle mass and the respective increase in insulin sensitivity, or if you will, it's basically whole body glucose disposal during an insulin clamp. But there was a positive correlation between the two in our study. And in the other research group that did it with clenbuterol, like they speculated more it could be related to more GLUT4 transporters. We didn't see that in our studies. We didn't see that in our own study.
You didn't see that? Okay.
No. And then there are numerous studies in rodents showing the same, that and most of them related to an increase in muscle mass. So you have an overall larger capacity for glucose disposal as such. And then there are some who claim that it's due to the skeletal muscle fibers being get a better ability to handle the glucose that's taking up and sort of like metabolize it further downstream, so that glucose 6-phosphate is not sort of like becoming the rate limiting
so it's
factor.
not building up.
Yeah, exactly. So it's not accumulating, basically.
Okay. And if people looked at, because you're talking about a euglycemic hyperinsulinemic clamp, you were saying there, to measure the insulin sensitivity. Have they looked at, to look at the insulin sensitivity, have they looked at the insulin signaling by any chance? Is that what you were saying? They've found changes in insulin signaling as well, or not?
With chronic treatment, they're like basically not studied in human. That's not been studied in humans, whether that's affected as such chronically. There are multiple rodent studies that looked into that, and some studies find upregulation on some of the kinases involved in signaling in glucose uptake. We do have a study. It's unpublished, where we looked into abdominal fat tissue from humans after 4 weeks of treatment.
Okay.
Without going too much into details, we do see an overall upregulation of various kinases, and also some proteins involved in glucose uptake. But obviously, I cannot disclose those right now, because it's quite new.
Okay. So the greater glucose disposal during the insulin infusion may be partly muscle due to the higher muscle mass, but partly also fat, maybe.
Perhaps, yeah.
Yep, cool.
Perhaps.
All right. How about we go to some of these? We've had quite a lot of interest on Twitter. A chap called Mark actually sent several through to do performance. So I wonder if I can ask you some of those. Is that all right?
Go ahead.
So in terms of performance enhancement and muscle hypertrophy / strength, how does beta-2 agonists compare to anabolic androgens, so steroids, I guess, testosterone, etc., and their analogs, creatine, beta-alanine, etc.? What is the estimated effect size? Because we've talked about that a little bit. So I guess, do you know, how does it compare to some of these other sort of agents?
They're not as potent as, for instance, like anabolic steroids or testosterone. So if you use nandrolone or whatever they could use, that like they get a way more hypertrophic effect of those. They will also get more side effects, obviously. But the effect size, like I alluded a bit to it before.
Yeah.
If we go in inhaled doses that are close to therapeutic, that would be around perhaps 0.5 kilo to 1 kilogram of muscle over 4 weeks. If we go high doses, as high as you could go is in a clinical trial, still due to a safety profile, we and others have shown that you perhaps can get like 1.5 kilograms over 2 weeks only, 2 to 4 weeks only. We had this study with salbutamol where they resistant trained for 10 weeks, and in that study you get around 1.4 kilograms more muscle than only training with placebo. So those are the effect sizes basically we do see, and I guess you can get a bit more with anabolic steroids.
It's probably similar to creatine's probably about the same, I guess. Another follow-up question he's got there: do other drugs, so again, and performance supplements, creatine, beta-alanine, work in synergy? Well, I guess we kind of touched on that earlier. And do some of them inhibit the effects of beta-2 agonists? So it was interesting you mentioned beta blockers. I guess did some of these drugs work in synergy? I guess we kind of talked about that, didn't we? And it would depend on the mechanisms. And then what about the effect of beta blockers on beta-2 agonists?
Well, they attenuate the effects, obviously, because they block the same receptors. Yeah. I mean, beta blockers in general, the ones we use are unselective. That means that they go on all beta receptors, also beta-1, and we also have some beta-3. But they obviously would do what's called competitive inhibition. So they would compete to go on the same side of the beta-2 adrenoceptor.
Yeah, so I guess you wouldn't, if you had high blood pressure and you're an asthmatic, you probably wouldn't go on beta blockers. They'd give you a calcium channel blocker or something instead, because you're going to, you wouldn't want to have beta-2 agonists, as you said, for your Ventolin, and then a beta blocker for your blood pressure.
They're contraindicated. Same goes with like, say, you have heart failure or something, and you have to go with beta blockers. You have to find an alternative than beta agonists. Then you go with anticholinergics instead, for instance.
Okay. I guess we've sort of talked about this. Based on empirical, mechanistic, hypothetical evidence and sports anecdote, we try and avoid anecdote if possible. In what sport does beta-2 agonists have the most benefit? So I guess we were talking about, strength type exercise rather than endurance. Yeah.
Yeah. So definitely, if you go for bodybuilding and you do see a high use within the bodybuilding environment, and it seems that they use it mainly to when they are off anabolic steroids, or to cut.
You mentioned that.
when they're cutting, basically, or else like their effects would be on sports or sports driven by power development and anaerobic energy production.
Yeah. Okay. And then Mark, again, is there tolerability? But again, we touched on this, but I'll just make sure. Is there tolerability to beta-2 agonists, meaning you have to cycle the usage for maximum effects, e.g. 4 months on, 1 month off? I guess you're saying if you're just taking the beta-2 agonists, then that would be a problem. But if you're taking the corticosteroid as well, then that's not really a factor.
Yeah. And I mean, some animal studies have looked into this a bit with emphasis on skeletal muscle, like where they then treat 4 days on, 3 days off, 4 days on, 3 days off, but it's not well investigated in humans.
Okay. Now, I saw you had a paper, beta-2 agonists induce net leg glucose uptake and free fatty acid release at rest, but not during exercise. So I guess just wondering about what's happening during exercise versus rest to metabolism.
Yeah.
Mm-hmm.
So basically, in that study, we looked a bit more into how it affects glucose metabolism if we give these substances, and again with an emphasis on skeletal muscle. So in this study, we looked across the leg in lean young men, and that's a pretty interesting model because we can put in catheters to see exactly what is going on, and the legs of such individuals have a very low volume of fat mass and adipose tissue. So we're pretty confident that the effects we look into are muscle effects. So and what's interesting there is basically, if you go around and read the literature, then it's said that when you give adrenaline, then you inhibit insulin's effect, and you inhibit glucose uptake, basically. So we're basically interested in seeing, okay, what if we give beta agonists? Then would we have a lower glucose uptake than say placebo? But we didn't actually see that in this study when we gave it into these young individuals and infused it. We saw that it increased the leg glucose uptake across the leg, indicating there is a significant uptake of glucose into the muscle at rest. And then we made them exercise at low intensity, moderate intensity, and high intensity, isolated knee extensor exercise, and saw that this effect was diminished, or at least changed or attenuated or whatever So sort of like exercise negated this effect, or that the exercise in itself, that there are so many mechanisms, intrinsic mechanisms going on that the drug in itself becomes
sort of overcame. Yeah. Mm-hmm.
Exactly.
That's interesting, because as you say, like, I think it was Bonin, maybe showed someone the adrenaline inhibited GLUT4 translocation and glucose uptake, etc. Maybe it was in rodents, but you're actually finding, if anything, just at rest, it's increasing it.
Yeah, and it's also a lot about the models that people use to claim something with regards to translocation of GLUT4. I'm not an expert in GLUT4 translocation, but I do know it's difficult to measure, and I can also see when I restudy that sometimes they show a translocation in one cell line, and then another cell line do not show that. Obviously, some of these epinephrine studies do see that it attenuates GLUT4 translocation, and then it can be inhibited. This attenuation can then be inhibited by beta blocker, and then people then say, oh, then it must be the beta receptor and the beta2 receptor. But if you go into the more recent literature where you use the very selective beta2 agonist, where you're sure that you look at the beta2 receptor, and there's a Swedish group from Tora Bengtsson who's done a lot in this area. Then they do see that it actually induced GLUT4 translocation in different cell lines, and also established it in animal models as well, and that this translocation even is independent from the normal signaling pathway you would see from insulin, for instance. So it's why something called GRK signaling instead. But as I say, I'm not an expert in this. I can only like state what we see in humans when we do it. We do see a glucose uptake, and we can see that some other people who works in other model systems are able to induce GLUT4 translocation with beta agonist.
Yeah, so I saw some talk about potentially having a positive health effect, therefore, in terms of, I know we talked about potential negative effects on the heart and whatever, but in terms of metabolism. So I know there was a study, clenbuterol exerts anti-diabetic activity through metabolic reprogramming of skeletal muscle cells. So these people showed, I think they had put them on mice on a high-fat diet and things like that, and the clenbuterols, the beta-2 agonist, actually overcame some of the negative effects on beta cell function and
was that
insulin
from
resistance.
West group?
Yeah, I'm not sure, but so is there a bit of a race? I saw something like a race for it being used for health or something. Is that a bit of a thing at the moment, or what do you think?
It's like it's becoming more like of a focus right now to understand this, like the beta2 adrenaline receptor and the putative potential role it could have. And I do know also in terms of these new drugs coming out that where they induce quite significant weight loss, people are also considering whether looking into a potential additive effect with beta agonists, so that the beta agonist would actually attenuate this too much loss of lean mass while you're on weight reducing agents such as semaglutide or whatever it could be, these GLP-1 agonists.
So are we saying if they were losing too much weight, the beta-2 agonist might slow that? Is that what you said, or did I get that wrong?
No.
Because usually that's not a problem.
Losing too much weight is not a problem. No, I have to be more clear. Let's say you have a 20 kilo weight loss. Some of this weight loss will be muscle tissue, but you would actually like to
maintain muscle.
Yeah, yes. Maintain your muscle mass. And that's where beta agonists could come into the picture, because we know that when people cut a lot of weight and are using beta agonists, then they can like maintain their muscle mass.
Which is important. Okay. Now, I think in your talk, you also touched on, I'm sure you haven't done much on this, but I just thought it was interesting. It might help with Alzheimer's. Is it?
Yeah, mainly Parkinson, but also there are some studies showing that Alzheimer's is associated or at least linked with a dysfunction of the beta-2 adrenoceptors. So there are some studies looking into whether you could rescue this aspect to it. With Parkinson, there are clinical trials ongoing where they looked into treating people with Parkinson with beta agonists. And that's basically because if you look at like very large epidemiological studies with several thousand individuals, you do see that people who are on treatment with beta agonists, they are less likely to develop Parkinson.
Okay.
And people who use beta blockers are more likely to develop Parkinson.
Okay, so it fits. Mm.
Yeah, but again, this is epidemiological studies, and they are not convinced of causation yet, but there are clinical trials, prospective clinical trials ongoing right now.
Okay. All right, so we'll start to think about finishing up. I like to ask about, are there sex differences? And I think you actually said the females might have a greater effect.
At least there are some. There are some indication. There are studies from Australia, actually, a group by Lee, who've looked into protein metabolism. For instance, they see with formoterol, which is a long-acting beta agonist, that there's a larger effect of formoterol in females in terms of protein metabolism. We've seen sort of the same in some of our studies, not all of our studies, but some of them. A recent study we've published on with inhaled salbutamol, we do see a sex-specific effect on body composition. So in this study, that's the study I talked about earlier, where the individuals were training with salbutamol 3 times a week endurance training. And when females did that, they lost around 2 kilos of fat mass, whereas we didn't see this effect in males. So there was a sex-dependent effect in terms of like cutting fat mass in that study, at least, and that was placebo-controlled as well. So there might be some sex-specific effects, but it's not like, again, it's at least for the chronic studies, it's not well investigated, and a lot of the studies also lack sample power.
All right, so that's interesting. Now, what about, is there age effects? Has that been looked at much?
Yeah, so there are studies that looked into it. I mean, both in terms of receptor content of beta-2 adrenoceptors and also like the responsiveness. And it's not like a clear cut that you could say that the effect wears off with age. In fact, it does seem as we are able to maintain our beta-2 adrenoceptor content with aging, and also the function of it. So in the studies that looked at that, like just general beta agonist pharmacology, it's not clear that the effect should wear off as such.
Okay, just thinking about that, because often when I ask about age, it's a situation where something changes with age, and I say, "Oh, but is that because of inactivity or whatever?" This isn't a situation like that. But it made me think: does exercise training itself affect anything? So, like, do you get more or less beta-2 agonists, for example? Do you know that?
Well, that's actually a controversial area, because there was a Nature paper, I think it was back in the 90s or late 80s, that claimed that endurance athlete had lower beta-2 adrenoceptor content than normal, like
In muscle?
No, they measured it in I think it was in blood, actually, just. And that was one of the big critiques later on, because it could not really be replicated when you look specifically into other tissues. So it's not like we can, and also when we try to look at it ourselves, looking at just beta-2 adrenaline receptor content in our studies, we do not really see it that it should change with that this much with training at all.
Okay.
So it's not clear.
I'm glad you brought that up, because I was thinking earlier you touched on how these beta-2 agonists may actually have negative effects with VO2 max and things. So, when you talked about training there. So tell me about that. How does that, so taking beta-2 agonists, is that acutely, chronically, can maybe have negative effects on endurance?
It can be both. I mean, if you go high enough in your doses, you could potentially have negative effects on endurance performance.
Oh, because you have a slow to fast transition, I guess.
No, not with the acute phase. Like if you do it acutely, it would be to you increase your energy expenditure, you increase your glycogen breakdown, so you're actually spending too much energy and relative to the work you're performing, and you wouldn't like that if you're an endurance athlete over longer distances. So that's when you go high. So that's the potential negative effects. It also makes some hemodynamic disturbances. So it dilates your arteries, and all of a sudden your blood flow distribution might also be affected a bit. So that the well-regulated oxygen blood delivery you do have when you normally do exercise, it may be disturbed a bit, because you will have some places where you actually are distributing blood you shouldn't, and you have a limitation in your cardiac output when you do at least exercise with a given muscle mass. So that's the potential negative effects. When we look at the chronically, the potential negative effects there are basically that you lower your VO2 max if you take beta agonist every day or train with beta agonists in high doses. So it's not all about building some muscle mass. You can also attenuate or compromise your performance, and we've shown that in some studies, quite a few studies now, also in close to therapeutic inhaled doses. So in one of our studies, we also saw it actually compromise some of the muscle function as well. So it seems like most of these effects on muscle mass are mostly cosmetic, if you will. There's not a one-to-one relationship with the increase in muscle mass that you then gain an increase in muscle strength.
I was going to ask you that, and then it sort of slipped away. Because I was thinking at one stage they were talking about growth hormone that might increase connective tissue, not so much the strength and things. So I was thinking about that. So you're saying so part of the effect of these beta agonists chronically, even though it increases muscle mass, you're not actually getting as much of an increase in strength as you'd expect.
No, that's exactly what I'm saying, and that's also what you would see with other substances that induce a big increase in muscle mass, that you do not necessarily see the same increase in muscle strength, for instance. That's shown in some of the studies with testosterone, for instance.
Oh, okay, so that's interesting. So is it like if you're increasing muscle mass by doing good, honest work, in sweating and things, then you'll tend to get, a more comparable increase in strength with it. But if you're just sort of taking an agent that increases muscle.
Definitely.
Wow. So you're taking this agent, it's increasing muscle, but you're not actually doing anything. Well, what about, okay, so I can imagine if you're taking this agent, whether it's beta agonists or anabolic steroids, that are increasing muscle mass, but you're not actually exercise training, then maybe you're not very good at recruiting it because you haven't been doing the exercise. But what about if you're doing the weight training and you take the beta-2 agonist? Do you get kind of normal increases in strength when you do that? Do you know?
Yeah, we've looked into that as well, and it's the same picture. You do see an additive effect on mass, but not necessarily on strength.
That's really interesting.
So the one study with salbutamol I talked about with the 10 weeks, they didn't increase their muscle strength more than the placebo group, despite them having way more muscle hypertrophy. They were able to enforce a bit, induce a bit more power during a sprint, but not in terms of isometric or isokinetic muscle strength in that study. And we showed the same with terbutaline in one of the studies where we gave high inhaled doses with resistance training. They did get an additive effect on muscle mass, but not on strength.
Oh, that's interesting. I'm glad that came out, because I was a bit worried that it was almost, we were just saying how you can get ergogenic effects, improving performance, etc., by taking these agents. But you're saying, as you said, cosmetic. It's quite a lot of it's cosmetic, so it's good for bodybuilders, for example, but maybe not. Yeah. Okay, that's interesting. All right. Now, are there controversies in the field? Because sometimes I'm interviewing people and I think, well, I'm not an expert on every area. I'm just taking things at face value. Is there anyone sitting around, a researcher, saying, "Hang on a minute, that's not what I found"? Are there controversies?
Yeah, I mean, in this area
science,
specifically related to the potential ergogenic effects and anti-doping regulations, there are definitely controversies with regards to beta agonists. And that's why also when you had the Chris Froome case and some of these cases with beta agonists and salbutamol, there's been an outcry from different camps because it's not clear cut. So there are individuals out there or groups out there who swear that inhaled beta agonists, they have no effects, whatever, and sort of neglect the studies out there showing effects. So there are some controversy, and as I say, like, what we really need to find out right now is are the dosing limits set such that they cannot by any means provide any unfair benefits? And I don't think that's clear as it is right now. You will not get huge benefits, at least, and you may even have some negative effects as we discussed, but it's not like that we know for sure under which circumstances there may be a ergogenic effect.
Right. Okay. Now, one thing I've started asking people is, part of the idea of inside exercise is to take on misinformation. There's all sorts of influencers out there and things that are saying things that aren't always backed by the research. Is there anything? Do you have like a pet gripe or something of something that you see out there that you think is not matched by the research?
So within my field, like, there are people that have some influence and also different stakeholders with much influence in the field who go around and claim that inhaled beta agonists have absolutely no effects other than in the lungs, and they sort of like just neglect all the studies out there across disciplines that do show that there is a large systemic component to this. They sort of neglect the basic pharmacological aspects of it. I think that's unfortunate because it doesn't help in this discussion as to what the regulations should be, basically.
Why are they doing that? Are they doing it because they don't want regulations on it?
Some don't. Some are in their like absolute belief and that there's nothing to it, and therefore there should be no regulations to it. Others think in the other camp that they should be more regulated, so that it's only specialist physicians who do all the proper testing who can give them a certificate. The problem there basically is then you just get a certificate, and then the certificate still gives you the drug.
Mm-hmm.
But it shouldn't be like that. You can just get a certificate for something and then get a putative benefit over someone who cannot get a certificate. So I think like the current regulations as they are sort of balanced in a way, but we still need to figure out where the clear cut should be for each of the beta agonists. And that's obviously a long process because that requires a lot of randomized controlled trials, but the regulations over at least the past 10 years have been slowly refined and become, I think, more fair.
Okay. It's funny that thing you said about, some people are saying the effects of these beta-2 agonists are only in the lungs, they don't get systemic, is a bit of a pet thing for me for a different reason. So I've had, bad asthma, and I've been all these different respiratory physicians until they actually worked out I had exercise-induced asthma by doing a hypercapnic hyperventilation test for people to know that you breathe as hard and as fast as you can for like 5 minutes, and they get you to breathe high carbon dioxide, well, higher than normal, so that you don't like faint and whatever. Anyway, so I got massively exercise-induced asthma. So it's like, well, at least they know now. But anyway, that guy, the respiratory physician, put me on the long-acting beta agonist with the inhaled steroid, corticosteroid. Anyway, I asked him at the time, I said, does this get systemic or does it just stay in the lungs? Because I was worried about the cortisol effects, the steroid. He said, oh, no, it just stays in the lungs. It stays in the lungs. And he knew I was a PhD in physiology. So anyway, and then years later, I got cataracts in my eyes. And the ophthalmologist said, oh, that'd be the inhaled steroids you're on. I'm like, what? And then I actually broke my neck of femur. I don't know if you know this. I broke my neck of femur in a bike crash. It was really bad.
Oh.
And a guy I was collaborating with is actually on the World Osteoporosis Council. He's like a guru. So he said, go and get a scan of your other hip and all this stuff. And sorry, when he saw the MRI, he said that shouldn't have shattered like that. He said, I think you've got low bone mass. So I went and got a scan. I did have low bone mass. He said, that'd be the inhaled steroid. I was like,
obviously.
So I go back to see the respiratory physician. Yeah, I'll go back to this first. And I said, you said it doesn't get systemic. He goes, oh, yeah, they got this new one now. And I said, yeah, but you said it doesn't get systemic. Oh, yeah, they got this new one now that's not so systemic. You told me. Anyway.
Yeah, and this is also what I've experienced within the field when I've done this research. It's a common misconception among respiratory physicians. And in fact, if you look at all the early studies with inhaled salbutamol when it was developed by GlaxoSmithKline, etc., I mean, up to 50% of the drug, of the effective dose you inhale, end up in some way or form being systemic. Inhalation is a very efficient way to get a drug into the systemic circulation. That's why anesthesiologists also use inhale anesthetics, for instance. All smokers inhale the nicotine or whatever. Yeah. And it's funny because this is also what you're telling doesn't surprise me at all.
I just figured he was saying it because he didn't want me to worry or something. But you're saying some respiratory physicians don't know that.
I experienced the same as you have, both in terms of like when I've worked together with them when I did my PhD, but also when we are getting our research out there, they sort of like neglect this because it must stay in the lungs.
Wow. Okay. Well, that's interesting. All right. So, so I'd like to finish up. This has been a good chat. Thank you very much. But with some takeaway messages. So, like when you give a talk, you want 2 or 3 things, 3 or 4 things, whatever, that you hope people will remember and take away from this chat.
Yeah, so one point is basically like, yes, there is a high prevalence of asthma and exercise-induced bronchoconstriction in athletes, particularly among endurance athletes, but there can be natural reasons for that. I think another important aspect is like to know that the beta agonists can be performance enhancing, depends on the circumstances, depend on the dose and testing, type of exercise, whether you take it acutely or whether you take it for a prolonged period of time. But it's also important to note that there can be some adverse effects, and there can definitely also be negative effects. So you may even inhibit your training and response and get a poorer VO2 max or an endurance performance if you use it too frequently during your training.
Yeah, that's very interesting. I was not aware of that. Well, I wasn't aware of quite a lot of it. So that's why it's I actually like doing these chats because putting out a podcast, but I'm actually learning a lot as well. So thank you very much for coming on. Thanks for your time. And
thank you.
I'll see Well, again, it's kind of funny, but it'd be, we're both in the same department. You're about 100 meters away. So I'll see you later on. Okay. See you, man.
Yeah. See you.
Bye-bye. Bye. I hope you enjoyed this podcast, and please like, subscribe, pass it on to your friends and colleagues. Check out the other podcasts. Thanks again.